Yes, thank you. Thank you once again. I think it's the second time I'm in such a thing. So uh, very interesting. And again, it's an evening. I think we have around an hour of presentation, and then probably we can have discussion. I'm trying to keep it very simple because delirium anyway. Most of you must have gone through. Otherwise, you wouldn't have been asked to get a case presentation. So it's going to be a recap. And well, 5M again, it's not a very old concept. It's a reasonably new one. It's a new concept. I think for the past 5 or 6 years, it has been discussed. It's basically how we communicate. It's a framework for communication, as we all know. It's a framework for communication, and there are 5 pillars. Sometimes it is 4M, where the multi-morbidity or multi-complexity things not included, but definitely there is 5M or 4M. These are the core pillars which we don't actually see it individually. All these 4 pillars has to be there in our mind. In all the communication framework or planning framework or preparing a care plan and whatever we do, these 5 things has to be in mind. That's the main concept. It's a framework for quality of life. How we deliver quality palliative care. So it again includes mentation it's about mobility, it's about multi-morbidity, it's multi-morbid condition. It's not just one disease at all. And the most important would be what matters most to me. It's my problem. So these are the 5 this thing. Just to start with. So in this session, you will be understanding the type of delirium. It's all a recap and then differentiate between the 3Ds. I think I have mentioned the 3Ds in my previous discussion. 3Ds are delirium, dementia, and depression. All three are sometimes very confusing. They can be there at the same time. It need not be separated. Sometimes dementia with depression, dementia with delirium, delirium with depression. So all this, like n number of combination can happen. So I have 2 slides on that. Then basically on practical management techniques for delirium and how we actually apply the 5M framework to improve care, especially in a hospice setting or in a home care setting. I'm audible and clear, right?
Yes, sir,
Yes,
you're
sir.
audible
Yeah.
and
Yeah.
clear.
Okay.
Yes, sir.
Thank
Can
you.
you be a bit louder? A bit
Yeah.
louder.
Yeah. Okay. So
Thank.
yeah, is it okay now?
Yes, sir. The audio is very clear. Thank you, sir.
Yeah.
It's
Okay.
fine now.
So within this presentation, you can actually stop me if there is a serious doubt, which you cannot resist to wait till the end. If there is a daring doubt which you feel it has to be interrupted and then only go forward, please do so. I don't mind. Otherwise, I expect a good discussion at the end, towards the end. So these are the 5 M's, which I'm not going to repeat again. So now let us just quickly recap what is delirium. That's the focus today we have. Delirium is nothing but we see patients or people, persons at home whom we say pichumbeyum parayunnu or talking irrelevant things. There is no not attentive. So all these complaints can come. It's basically an acute disturbance. Means it's not for a long time. It starts suddenly. Acute means something starting very suddenly. So it's an acute disturbance in attention and cognition. Cognition, it's basically decision making. It's understanding how you understand the world. Like all those things come under cognition. So what makes delirium different from others is it is rapid. The onset is rapid. It has happened suddenly. Till yesterday, like everything was okay. Suddenly, today morning, or suddenly within few hours, everything has changed. Or within one day or 2 days, suddenly there is a change. So there is a rapid onset. And the other hallmark, the very important hallmark of delirium, which you can differentiate from dementia or depression, is the fluctuation. It's a fluctuation throughout the day. So some part of the day they'll be fully okay. So the relatives may come and say he is not bad all the time. Sometimes he is very okay. Sometimes he talk well. He recognize people. He is talking sense, or he or she is talking sense. But sometimes suddenly he loses his mind. So that fluctuation during throughout the day is a hallmark of delirium. And mostly the delirium gets worsened towards the end of the day towards evening and night. And the delirium may be worst during night or even late night or midnight, after midnight. So it goes worsen. And we call it as sundowning. Sometimes it is called as sundowning. When sun goes down, the symptoms go up. That's what it means. So sundowning is a definite phenomena which we see always often in delirium. So we also should understand it as something to do with the cycle, the day and night cycle, the biological clock within us. It gets disrupted probably. So that is one reason. And how long does delirium stay? It is usually days to week and usually reversible. Usually. Sometimes delirium is towards the end. It carries very bad prognosis. Sometimes somebody who goes into delirium has a very bad prognosis. So prevention is always better. It should be always done. And otherwise, if good care is taken, delirium is usually reversible. The person come back, and it's days to weeks. But during terminal stage of life, probably if it is a terminal stage of life, delirium is usually naturally following. So it naturally follows. And again, we need not be very much worried in a sense that it has to be corrected with lot of medication. So there is a judgment which we have to have. Sometimes a person can go into delirium towards end of life, and that we have to manage separately, not to reverse delirium. Our principal aim is not reversal of delirium, but quality of life and maximum trying to keep the person oriented to time, place, person. Those will be the priority. So duration has got some importance in palliative care. If it is geriatrics per se, we always try to revert, prevent, revert, and all those. Sometimes in palliative care, um, uh, because we are not worried about um, the adverse events which is otherwise beneficial, quite controversial or debatable, but that's where we end up. So in such situation, reversibility is not the primary focus. So we have basically three type of delirium, basically. So it may be hyperactive, means the person will be very much agitated. Agitated in the sense he may be abusive, he may be restless, he may be staring at you. So all these things, all these agitations may be there. Somebody who is physically very active can be very abusive and abusive physically also. Somebody who is bedbound, we can actually understand from their facial expression, from the way they stare and all. Probably they may not be able to move their limbs to show their aggression or hyperactiveness, but you can actually make out from the eye movement, uh, the facial expressions, and on the forehead, the wrinkles on the forehead read a lot. So hyperactive delirium is one. Then second would be hypoactive. It's the exact opposite to hyperactive. Means the person will be very much lethargic all the time. A lot of inattention would be there. Not actually looking at your face or responding. It looks like a, a drowsiness which is long standing. But again, sometimes he may be drowsy, sometimes not drowsy. So it there is a waxing and waning of cognitive status. So that is hypoactive. And sometimes there'll be alternating hyperactive and hypoactive. At some time of the day, the person will be very hyperactive. So it's hyperactive delirium and sometimes hypoactive, very dull and lethargic. So that is mixed. So basically, hypoactive, and mixed. Hypoactive delirium usually gets missed out. So we may feel he is comfortable, there is no pain. So it may not be always true also. Very difficult to identify delirium in this case. So it all comes with experience and talking to them and the continuity of care. If you are keeping on seeing the same patient again and again, the person again and again, all these situations can be clearly identified. Or otherwise, working with the relatives. Relatives are the best person who can, relatives or the caregiver are the best person who can actually tell this is not the way he is. He is too silent today. I don't think it is because he doesn't have pain. He's not feeling good. He is very drowsy. And sometimes he is very aggressive, or sometimes he is normal, but sometimes looks very pathetic. So it is hypoactive. So keep in mind there are three type of delirium. So it's not the prevalence is very high. Um, I found few journals which say in palliative care 1 in 2. If you see two of them, 1 in 2 in palliative care, especially in hospice, now they have delirium. So, or towards the end of life, it's not always. It's not generally in palliative care. I think when I typed it, that point is missing. But it's not generally in palliative care, but towards end of life, it is almost 50%. And hospitalized elders, the prevalence can be up to 1 in 3. Around 30% can experience delirium sometime or other. So in a hospitalized person, delirium is very common. And this 30% can go up to 30, 40 or 50% or 60% in ICUs, where the person is suddenly isolated with a lot of sounds around, unfamiliar situation, and no access to sunlight. So unable to understand whether it is day or night, and suddenly the disorientation will set in, and it is delirium again. So it's not just ICU or anything. Again, other risk factors are multiple medication, which many of them have. So one of the intervention is stop medicines which are not really required. You have to be really bold. I'm not saying everybody should stop medication, but talk to a doctor who has a palliative care inclination and see whether really the medication is required or not. If it is not required, be bold enough to stop it. But tell the patient, relatives, or caregivers how it is, why this has to be stopped. Because polypharmacy is a definite reason for delirium. And most common is dehydration, which is often missed. Sometimes a dehydration cannot be avoided. Again, palliative care, we have to see palliative care at which stage of life. Palliative care can be for very active person also. So for an active person, dehydration is a problem. We have to correct dehydration, ask the person to drink more water, and also tell sometimes dehydration, there may not be any sign or symptom. Even thirst may not be there in older people when there is dehydration. So dehydration can be without thirst also. So in geriatrics, we have to be very cautious. Dehydration is a major risk factor. In palliative care, at some stages of palliative care, dehydration need not be corrected also, which is not the point of discussion today, but I'm sure you all understand and are sensitive in those matters. And sudden infection, in any part of the body, it can lead to delirium for sure. We have seen delirium even for a common cold or even urinary infection or up to meningitis or very severe infection, whatever. Any infection can result in delirium. So any condition in in an aged person can result in. It's not just infection. It's just one of the example. Any infection, any sudden change in body function, dehydration or medications can be um, the cause for delirium. So this is next two slides. I have some comparison. How you quickly differentiate between delirium and dementia. Whatever I said now. Dementia would be gradual. The other one is sudden. And in dementia, it is a gradual decline. Suddenly, one day the person don't decline. It's a slow process. It may take months to years, or at least months for a decline, and it's going to be very steady, a steadily declining cognitive function. Um, and in dementia, usually attention is preserved. In delirium, the person will not be attentive. Whatever you try to say, it's very hard to get his attention. But dementia is not like that. You can actually talk to that person and get his attention at least for some time. And dementia is not reversible; it's a progressive thing. But some dementia, while saying this, some dementia are reversible also. But that is not the scope of today's discussion. But some dementia, because of some nutritional deficiencies like vitamin B12, or some of the vascular dementias, or hypothyroidism related. There are many conditions where the person may have dementia, but those dementia are reversible. But generally, when we say dementia or Alzheimer's dementias are not reversible and they are progressive. So this is the comparison between delirium and dementia. And in the 3Ds, the next is a depression. Depression also, just like dementia, it is gradual. It's gradually non sudden. There can be a grief. We have to differentiate between grief and depression. That I'm sure you'll be having sessions on that. If it is depression, it's going to be gradual, and delirium is a rapid onset. There is a mood again. Uh, in a depressed person, it's persistently low or very low. It cannot be very good at times and low another time. There can be masking. Sometimes there can be a masking of depression, but mood is generally persistently low in depression. And attention also is not that much of an issue. Some sort of sustained attention is possible for somebody with depression. And depression, there can be apathy, which may actually get confused with hypoactive dementia, apathy towards everything. But again, it gets improved when we with counseling or good psychosocial support, even with companionship, even spending some time with that person with apathetic depression, some improvement can be seen. But in delirium, such improvement cannot be seen, but it fluctuates. So that is all about this thing. Then how do we identify delirium? So basically, anybody with an experience of delirium, if you have seen few persons with delirium, then it's not very difficult to identify whether it's delirium or not. With the history, basically, it's a history which says it is delirium or not. There are no blood test or any uh, what do you say, any radiological investigation which can uh, diagnose delirium. It's basically history. So as I said, it is acute in onset, fluctuating. There is a waxing and waning nature. There will be profound inattention, and the thinking will be very much clogged. There will be it's totally disorganized. The person will tell all unconnected things, a difficulty in recognizing person, disorientation to time, person, and place, and definitely, like as a result, there is an altered consciousness also. So in the CAM, which is confusion assessment method, delirium is diagnosed if three of the four conditions are there. These are all general things. And the first two one are very essential. If it is acute in onset with a waxing and waning nature and has an intention, and one of the third and fourth, which is disorganized thinking or altered consciousness, then it can be classified as delirium. So delirium can actually impact on mobility. So once we are thinking in the 5M framework, one is mobility for sure. Sure, we have to think of mobility is a mentation which we have discussed so far. Now it's a mobility which is again it definitely affects the mobility of a person, and it can result in significant functional decline. Functional decline again. You have to recollect all the activities of daily living and instrumental activities of daily living. Forget about the instrumental activities of daily living. Somebody who has a delirium, at least we have to maintain their activities of daily living. Otherwise, functional decline is going to be profound, which can again be very much detrimental for the person. In palliative care, again, think I'm just reiterating again and again because you have to keep in mind I'm telling sometimes in very general terms. In general, very general terms in geriatrics, where palliative care in geriatrics, when you see palliative care in geriatrics, some of the things may not be given too much of importance compared to improving quality of life or you know, giving dignity, autonomy, all those things. For example, we have to definitely prevent falls and bed sores because all those things are painful or affecting their dignity, whatever. But sometimes bed sores are there, and treating bed sore may not be our first priority in some cases. So all those things, I'm just reminding you because it's a geriatrics is a broad subject, and palliative care is one important component of it. And within palliative care itself, an older person can be very active and under palliative care. And again, the person can be in a terminal state still under palliative. So, general terminology is what I use here. Don't get confused. Sometimes I'm being very general. That's all. So, in general cases, early mobilization should be our priority to prevent all the functional loss and slowly start activities because each day lost will further decline. There will be a further decline in functional capacity. So use whatever technology we have, whether it is assistive technology or personal care, providing personal care like repositioning, hygiene, all these things has to be considered. So again, as I said, polypharmacy, medication, when you think about medications, um, there are a lot of drugs which are offending. There are offending drugs. Means those drugs are not good always. It's not that modern medicine is bad or anything. A doctor or a healthcare worker should be very vigilant. Should be very vigilant. One good thing is every healthcare professional who is in modern medicine should have the basic knowledge of what medicine do to the body, how it affects the physiology, how it affects the mentation of a person, and early identify any adverse reaction or adverse event. It need not be an allergy or anything. It can be even delirium or such things. So whenever there is a doubt, like something is going wrong, then go revisit the medication. Any even opioid sedatives, all these medication which I have written here are being used in palliative care. So again, going back to what I said earlier, sometimes we have to choose between the devil and the deep sea. One is the devil is the offending drug, and deep sea is the delirium or whatever. So sometimes it may be beneficial, again, point to discuss and point to debate or whatever. But all these things are case to case. As you all know, in palliative care, there is no general dictum and there is no general algorithm that we have to follow. Every person is individual. So sometimes in some stage of life, when a palliative care doctor a, or a healthcare professional have to increase probably the a dose of certain medication if required, not always, so that delirium may set in. Then managing the symptoms also have to be considered. So that's a different set of discussion, especially when we come to end of life medication and end of life, how we manage medications towards end of life. These things has to be dealt separately. So whatever the practical tip would be, generally review the medication again and again and again. There is no single prescription for lifetime. It has to be reviewed. And sometimes polypharmacy is very bad. We have to cut down all the medication, probably one or two or three, or even one, or sometimes no medication would be the best treatment for that person. So coming to delirium, back to delirium, uh, uh, there are the, there are again simple and pharmacological measures as well as non-pharmacological intervention. Pharmacological, again, a doctor has to prescribe. Generally, haloperidol or quetiapine are uh, are the standard ones which we use in palliative care, if at all required. Non-pharmacological, we all know it's just a cognitive stimulation. The environment should be kept very calm. It shouldn't be very dark. It should not be very brightly lit. It should be a warm, light littered environment. If it is daytime, sunlight would be the best with good ventilation, so that the person would be able to understand whether it is day or night. And then in cognitive stimulation, don't try to ask questions. Always stick on to statements. Don't ask, do you know him? Did you recognize him? Instead, tell this is so and so. He has come to meet you. If the if visitors are not doing good, refrain from getting visitors. Let them not come in the room. Still, it is okay. If the person welcomes, then only visitors has to be there. Otherwise, excessive stimulation also may not be really good if it is not appropriate. Because somebody may come and ask too many questions. What are you doing? Did you eat food? Lot of questions. All these questions may cloud this person and again. So cognitive stimulation has to be done very carefully. Then if the person has some sensory impairment, make sure that is being taken care, especially a reading glass or whatever, and hearing aid should be given if he is using. Then put a big clock in front or a calendar in front, and in the calendar, if you can mark the date today, something like that, it all like all these things help. So this is in a in case of multi-morbidity. Again, in multi-morbidity, we have to take a call what has to be treated, what need not be treated, or how to treat. All these things has to be communicated with the a person if possible. That should be a first priority wherever possible, and consider autonomy of the person when taking a decision, especially in palliative care in geriatrics. Uh, in geriatrics, definitely it's going to be there is going to be multi-morbidity at the same time, and multi-morbidity, and more than that, it is multi-complexity. Multi-complexity means it's not just a disease; it's a disease with physical condition, curable, incurable, debilitating. Then again, which has got a psychosocial impact, environmental impact, climate change. Somebody's house is not built appropriately to resist the heat. So climate change, including climate change, can affect palliative care. So these are things which we have to keep in mind. It's a big subject, in fact, the multi-complex nature of uh, geriatric care. So palliative care in geriatrics has to be worked in good connection, good collaboration with good relationship with the patient or the person. We don't have patients sometimes. It's a person with the home care team, the palliative care system, the families, the carers, sometimes the relatives. Sometimes the neighbors or friends. So all of them has to be consulted. Good coordination has to be there because sometimes it is long-term care also in geriatric care. Long-term care has to be considered. We cannot say somebody will be living with a condition for few months or few days. So in geriatrics, it can be a long-term thing. So internationally, in healthy aging discussion or all this discussion, people talk about now there is a strong discussion going on long-term care. How long-term care can be provided. The long-term care can be actually very long-term, quite long-term. It need not be what we have in mind. Sometimes our care plan may end abruptly, and we land up in a situation where we start think, "Ayo, no, we don't have a plan anymore. What next? We had not planned. It was so surprising, and it's not going as we predicted." So long-term care planning has to be very meticulous with expecting lot of surprises, and the society itself has to be changing. So in the long-term plan, think of alternatives, and because it is multi-complex and multi-complexity is there. So think of more collaboration in terms of involving even the community, other community power structures. Everything has like everybody has to be there in place, especially to have a good coordinated care for the person. Am I going very fast? Because any doubts or any clarification at this point?
Hello.
Yep.
Hello. This is
Yeah,
Dr.
I can.
Ichkedas.
Pardon?
This is Dr. Ichkedas from Assam.
Oh yeah. Hi, Dr. Das.
Hi. Uh, the reason what you are saying is very much true, and we do see when a geriatric person is admitted in a OPD ward, either at a government hospital or at a private hospital, they are bombarded with medications, right from orally, IV, all these things going on, without finding the actual cause. Either it may be due to dementia, or it may be due to delirium, or maybe depression. These causes are rarely taken in account by the consultant physician itself.
Yeah,
In
correct,
my
Das.
setting, I
You're
see. In my
absolutely right.
setting at the time,
Yeah.
whenever a patient comes, he is bombarded with medication. These investigations, medication, diagnostics, or whatever, the patient history is not elicited out. What is the actual? Probably he may have benzodiazepines or cholinergic opioids or something like that. So it is. I feel that impulse is there. That some sort of thing is this intervention is really needs at this level.
Because again, Dr. Das, if we can, and others also, if the doctor or the
Right.
decision maker for the treatment, because
Yeah.
most of the time it's the senior doctor or the doctor in charge is a decision maker. It's not the
Yes.
relative
Not the relatives.
or the patient. They are not deciding.
Right.
They don't have much autonomy. So if we actually consider the four cardinal principles of palliative care, like or the
Right.
medical ethics, it's not even palliative care. It's the cardinal principles of medical ethics, like beneficence, non-maleficence,
Right.
autonomy, fair use of resources. If we have all these four pillars in mind and this
Hmm.
5M in mind, if these things are there in mind, it becomes very easy. It's very easy. It's very easy in the sense it's very easy to communicate with the patient or the patient relative or carer and try to make him or her understand what is actually happening and what is
Well
going to
said.
happen in the immediate future. Then all these confusions are gone. So basically, this very awareness about geriatric care, about what happens as somebody ages, is more
Hmm.
important.
Yes, yes, yes.
Very thank you for the comment and breaking
Thank
the
you.
ice. Dr. Das, actually, thanks a lot because I was going very monotonous and I was keeping on talking. At some point, I thought, oh, am I going very fast? Am I just talking? So thanks a lot. So let me continue again.
Right.
Thanks a lot. Yeah. So next is again, as we told just now, it's just aligning the care. As we just discussed, the goals are more important. That's where the decision making comes. A doctor or a care provider may provide what he has in hand. I have these many medicines in my kitty, in my cupboard. This is what I'm going to give. This is all I can give you. If that is the intention, then nothing works out. So what matters most is more important. So I'll just reiterate one of my personal experience long time back, 2 decades back when I was a junior doctor. When I was a junior doctor in Amrita Hospital, I just came in. I didn't know anything about geriatrics. So we had few faculty from US who were training all of us. So I had my senior doctor, Dr. Sunil was there. Uh, being junior doctor, we like our role was to talk to the patient, talk to the relatives, and make a problem list. That is very funny. In my house urgency or like anywhere, I never made a problem list. We always made a diagnosis list, differential diagnosis and diagnosis. So this is problem list. And the junior doctors were not allowed to write differential diagnosis also. That was a condition in geriatric department. So we make a long problem list. There was a Dr. Dory Rosenblatt. I still remember on my first day, she didn't shout at me, but she was very stern. She told Dr. Pai, you have to make a detailed problem list. This person has at least, every person around us has got at least 10 or 15 problems. If you can't find even five, means your history is bad. History taking is bad. You go back and talk to him again. Then I realize it's true. It's not just the physical condition or things which are the problem list. So that was the first thing which we learned, making a problem list. And at the end, after we make a problem list, it has to be prioritized. That was the exercise. That was the worst. That's the most difficult exercise. It's not the worst. It's the most difficult exercise I found. That priority has to be done. Prioritization is from the patient's end. So there are 15 problems now, which I have to write in another paper and then prioritize. Talk to that person. Tell. So these are things which you have told me. So what matters you most? Then came the real magic. Our differential diagnosis is not their priority at all. That's not their priority. Their priorities and preferences and goals are something very, very different. So when the prioritized problem list came, the differential diagnosis which we make comes towards the end or towards the middle. It's not the first one. So this is what we have to understand very much. And always this is possible only if we can involve the caregivers and who understand their wish actually. A caring or a loving a relative or a caregiver can definitely understand what actually the person wishes if it is what has to be done in a particular situation. Without knowing that, we cannot. So basically, it is something like it's, it's a family education or the person's education and support, which is very, very important. Keep it very simple. We don't have to. Sometimes doctors or health workers put in a lot of medical jargon because then there won't be any question because they didn't understand. Only they will ask you question only if they understand. So a lot of jargons will be there. In two sentences, there will be at least five medical terminologies. So reduce that. We have to understand. that the explanation has to be very simple, but don't compare with a very simple things so that it's oversimplified. They may not understand, but simple explanations are good. And try. And what is the goal? What is our aim for such explanation? Why an explanation has to be given? When I asked a doctor, he said it's a legal provision. I am supposed to come out of my ICU and give an update. That is why I give explanation. Well, it's actually the other way around. If we if you are in their shoe, it's the other way around. I am trying to understand what my relatives or my son or my daughter or my husband, wife, father, mother, or my sister. I am asking about them to a doctor. It's because I am anxious. I am anxious of what is happening. My very reason for inquiring or getting an update, waiting for hours with lot of curiosity to meet the doctor for 5 minutes or 1 minute is because of anxiety. So the very goal, the purpose of a doctor or a healthcare professional for giving simple explanation or an update should be to reduce the anxiety of the person or the family. In case of delirium dementia, it is relieving the anxiety of the family or the carer. In case of depression, it's all like all of them. So again, coming back, this is again a recap. This is a quick recap which I have made. These are the prevention strategies. And in long term, if at all, I'm telling you, sometimes geriatric care can be very, very, very long. It can go for years. They can be with us in palliative care for long term. So beware, don't give short term expectations or short term what do you say promises. Sometimes it may not work. We will be in trouble. So do a very good homework, do a very thorough groundwork, and prepare a care plan for a long term. So even with in this case, this particular slide I have made in connection with delirium. So we are expecting sometimes, if it is not a terminal delirium, then it is we are trying to reverse it or better it. So post delirium, we had to keep on doing cognitive assessment and again assessing for long-term cognitive decline and functional decline also has to be considered. So now I'm not going into case scenarios at all. I have got three scenarios. The same. I already told there are three type of delirium. One is hyperactive. The second one is hypoactive, and the third one is mixed. So I have just put this picture to show how prickly or how sharp or how hyperactive is going to be. I don't know whether the picture I have put is appropriate, but this came into my mind how it actually feels. Handling such a prickly or with lot of spine, handling it. That is that much difficult handling sometimes a hyperactive older person with any ability. So this is hyperactive. Hypoactive, the person is going to be very pathetic. So just um, you think about a scenario or think about what you have seen in past. So recollect some case histories in the past. You tend to understand whatever we have told here. It all fits in place. So this is again mixed. You don't know. Sometimes it is like this, keeps on changing from one time to another. So this is how we are going to do. This is the framework. So along with that, when Dr. Das put up that question, we told we should have uh, all the cardinal principles of ethics in our mind that should guide us. That should be the guiding force in front of us. All the four cardinal principles of bioethics, the personal ethics or medical ethics, and all these five M's in mind. So that will actually give a good framework for our thing. So these are the summary points which I have for you. One is, the earlier you uh, identify delirium, always it is better, because delirium is very easy to identify. Somebody with a reasonable skill can tell today this person is not doing good. Till yesterday or till 2 days back, he was behaving almost same way, but for the past 1 or 2 days, or since yesterday or since today morning, this person is behaving something odd. And sometimes of the day, he is not doing good. His mental status is not correct. So this should trigger a doubt. And then suddenly we have to think of the 3Ds. So dementia or depression. Is it dementia or is it depression? Probably the person had very baseline or an early dementia, which was not noticed, and suddenly fever set in or some minor infection come in, and because of the minor infection, the dementia became prominent. So there can be dementia with depression. So that is also possible. So somebody with dementia, it becomes very complicated in such a situation. We should also understand a person with dementia may get delirium very fast, or somebody with depression may end in delirium quite early or with minor issue, because it's a delicate balance of mind which is keeping the cognitive status intact or the orientation status intact. Some biochemical or metabolic issues or some environmental issues itself can create delirium. I'm once again telling you, it looks very odd, but climate change can cause delirium. Climate change should be one of the could be one, not should be, could be one of the reason for delirium, especially in hot climate. The heat waves coming in, we don't have good guidelines for it. Our houses or hospitals may not be really apt or appropriate for managing. It's not air conditioned, or we don't have HEPA filters. We don't have laminar flow systems in our hospitals, in normal rooms, or in our houses. Sometimes we do have sick buildings. I don't know, you have heard about sick buildings. Sick buildings are buildings which don't have good ventilation, good lighting. So inside the house, the environment is really bad. So when climate change affects, then it very adversely affects the most vulnerable people. Those are the older people, and hence all these issues, all this delirium, dementia, everything, whatever name everything, it has an impact. And our palliative care intentions, how we are planning palliative care also may not be going as we plan, because we have not factored it. The environment has a very good impact. So keep in mind identifying delirium early, and look for the contributing factors. Contributing factors can be anything under sun, including the sun. That's what I meant. So look for the contributors and intervene accordingly. And if at all there is a doubt, always do an assessment with CAM or whatever, because documentation is very important. Tomorrow we cannot say, he had delirium for 5 days, but that is not the appropriate way of dealing. We should have some documentation, use the CAM, say these out of the four, these were the three, or these were the four points which were there on, say, 10th of October. So on the 15th of October, again you see, okay, these many points are there. And again at the same time, do the ADLs and say how many activities of daily living are being taken care during this time. Is there any functional decline? So all these things are interconnected. So do assessment regularly. If at all, not the comprehensive geriatric assessment all the time, but every person should undergo a comprehensive geriatric assessment at any stage of time at the starting. Then wherever that assessment could not be done earlier, do it at some point of time. mark the date, and every date the others also has to be updated. So assessment is very important. I've just written CAM here because the topic here today is delirium, but do a full assessment all the time. Well, again, manage delirium or any other condition. Keep those five M's in mind. It's very important. If we have the five M's in mind, it's very easy. It's very easy to plan. It's very easy to do to make a care plan, long-term care plan. It's very easy to communicate. It's very easy to prescribe medication, whatever. In palliative care, good quality care in palliative care comes if we can think of these five Ms. And always involve the family and caregivers. And again, it need not be told again and again. Communication is more important, and out of communication, always listen, 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 again, listen, 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 and still keep on listening and keep on listening. That's all. Communication is very important. Listening is most important because most of the things come out of history only, and history can be elicited only if the person is a good listener. And this is very, very extremely important in palliative care. And prevention is the key. Again, another key. Delirium can be prevented. If we understand what causes delirium, what are the contributors to delirium, then it is easy to prevent whatever. In palliative care, one of our dictum is prevent the preventable. We cannot prevent everything, right? We cannot prevent everything, but whatever is preventable, prevent it. And that will prevent delirium also. So medication, polypharmacy can cause prevent it, but you cannot prevent an infection if it has set in. But you can prevent the infection that can go out of hand. In that case, we have to always think about the atypical presentation which can happen in aging. So all these contributors has to be kept in mind, and then it can be prevented. So these are the summary which I have, and I think it's almost an hour now, which I have promised to keep you engaged. So if you have any questions, you can. I don't know whether you can chat here. I think I should
Yes,
exit
sir. Yes,
this
sir.
sharing.
The participants can uh, post their questions on the chat box.
Okay.
Doctor, excuse me, I am Dr. Anandam here. I
Yeah.
just have one question. In this delirium, I have seen patients with metabolic imbalances coming out with delirial reactions. So I think that should be also mentioned, especially hypoglycemia and hyponatremia together when it comes. The patients sometimes become delirious and in a hypoactive way, more
Yeah.
than in a hyperactive way.
So metabolic, all the physiological imbalance, including
And even constipation,
metabolic disorders, can result in delirium.
chronic
Including
constipation. also.
Yeah. Constipation, wonderful, wonderful. Constipation also, everything. Any physiological alteration can result in delirium. You cannot predict, and it's so atypical. Like sometimes it can be, and delirium could be the only sign like falls or another such things. Delirium can be the only sign to identify a condition, a condition underlying.
Times that has happened. That's what
Thank
I've
you.
seen.
Thank you for bringing up. Thank you for bringing.
Okay, thank you, doctor.
Yeah.
Hello, can I ask
Yeah.
question?
Oh, sure.
So this hypoactive delirium, is it difficult to diagnose also? No, so how there is any assessment method for hypoactive delirium
Hypo.
and how to manage? It's very difficult thing.
Yeah. Very difficult. Actually, it is not difficult when we work with relatives also. Sometimes I tell you, some confusing things may happen. Somebody who is in excruciating pain, we give pain medication, the pain goes off, and the person starts sleeping, looks very comfortable. So whether that comfortable sleeping or stage whether it is delirium
Okay.
or not. Sometimes it may be confusing, but when we start talking to the person, we can identify the disorientation sometimes, or the disorientation, or the relatives may say it's not the usual condition which we see. It's not
Yeah, but
like this.
sometimes when the patient is sedated or they're ventilator also, so that
Oh,
time
that's
there
a
is
different
sometimes they
scenario.
have agitation or something is there. So how to differentiate all those things, that becomes very difficult for hypoactive. That's what I feel.
Sometimes it can be mixed also. Very difficult.
Yes.
I don't have an
Yeah.
answer. Sorry, I don't have an
Yeah,
answer.
I know.
You are
That's what I
absolutely
was.
right.
I just wanted to
Yeah.
ask. Everybody is facing the same problem. So just
Yeah, yeah.
wanted to clarify that.
Delirium, identifying delirium is easy. The person has delirium, but sometimes delirium can get missed also. When the person is medicated, the person is
Hmm.
medicated is very difficult to identify whether the person is actually delirious or not.
Yeah. Hmm.
Sometimes good pain control can result in the person. Sometimes somebody is agitated with pain.
Hmm.
We are not going to say the person is delirious. We will say the person is in pain, and because of
Yeah.
the pain, the person is behaving like that. He can't think.
Hmm.
He is aggressive. So now you give a good pain medication, the pain goes off, and then suddenly the person becomes very passive. Then we may feel the person is better now. Maybe it is
So
a
it is
mixed
basically a
delirium.
diagnosis of exclusion, I think,
There
you have
is
to exclude most of the things.
maybe it is a mixed delirium.
Yeah.
But my personal take would be, correct me if I'm wrong. There is no there is no absolute answer to all these things. We are all working in the field, or like most of you. So everybody has an experience. My experience is sometimes I have felt I have not corrected delirium in most of the in some of the conditions at least. When somebody is a hypoactive delirium with good pain relief with opioid. And if I find the opioid is the reason for delirium, it's very hard to bring down the dose of delirium or add another, quitipin or something. Sometimes it's very difficult to make a decision. It has to be taken with good care. So even sometimes somebody has tried I don't remember what was it name? Uh, it's a stimulant. It's a stimulant. Some people try stimulant
Mode
in
alert.
case.
More
Mode
Yeah,
alert.
alert.
mod alert. There is one more, right? Mod alert is one. So all these stimulants are used to increase, alertness um, um, in a hypoactive delirium. It doesn't work. It doesn't work. Not that it doesn't work. It will aggravate delirium. The person may go opposite, totally opposite. The person may go exactly to the other end. So we have to be very careful also when dealing with delirium, trying to correct delirium. As earlier said, look for correctables. Sometimes it is dehydration, sometimes it is some metabolic disorder going on, which is correctable still. So correct those things, and then delirium can be controlled because delirium will
Uh,
bring down the quality of life, definitely.
Sir,
So as yeah, tell me.
sir, we have a few questions in the chat box. So, Dr. Harsha has asked why delirium is most common at the end of life.
Well, and like I won't say delirium is common in end of life, but I would say delirium is seen in end of life. Because during end of life, there is lot of things happening inside the body. Some of the things which we know, and some are unknown to us. Many of the metabolic pathways which go on in end of life, if we actually let it natural, so it can, for example, metabolism. Metabolism in end of life is totally different. If we ideally, if you don't force feed the person, if you don't force feed the person, or if you don't force push hydration, then the person is definitely going to go into a mild dehydration, ketosis. Some ketone bodies will be released in the blood. So all these things will definitely take to a delirious condition, which may be beneficial also. I don't know. It's quite debatable. But delirium is seen, and terminal agitation has to be managed. If the delirium or whatever we name it, delirium or whatever name we put, if there is agitation, it has to be managed. It's not a good thing. But otherwise, delirium is always there towards the end of life. It's only very few persons practically I have seen. My experience is almost 2 decades now. So very few of them were extremely conscious during the last 1 or 2 days. Extremely conscious in the sense who can understand everything and suddenly collapse and die. They are a minority, and majority usually towards the last few hours. Definitely, there is a mild delirium, mild clogging of thoughts, some cognitive impairment, some memory lapses are there. So that is beneficial. Rather than keeping the person very alert, the more the person is alert and more the metabolic functions are kept intact towards end of life, there will be more pain and other things. So I'm not advocating going for metabolic disorder or metabolic
I call
imbalance.
it
It's better.
nature's anesthesia.
Agree. I didn't have a good word, good way of putting it. Good way to put it, Doctor. I
Dr.
appreciate that.
Pai, Dr. Pai, how you treat the diurnal, that variation? They wake up at night and they sleep during daytime.
Okay.
So what is the treatment, or because that is the most
Yeah.
disturbing incidents for relatives?
Correct. See, there some non-pharmacological mechanisms can be utilized. For example, keeping the person alert during daytime, not letting him sleep. But it's not always possible. Especially if you're looking into very in a terminal situation, don't attempt that. Leave it to nature. Let the person be comfortable. We may have to be awake during the night also. But otherwise, managing delirium prevent the person from uh, uh, sleeping during the daytime. There is a sleep reversal. Sleep reversal is the issue. Sleep reversal is one of the hallmarks. So the person will sleep during the daytime, and then definitely there is sundowning, and the sundowning is going to keep the person alert, and then all the disorientation will set in, and there is stimulation. If there is stimulation from outside, like bright light, people talking, giving food during odd time, like all these things will keep that person more alert, and he won't sleep. So best would be giving a good environment where calm and low lit environment where a sleep can be promoted during the night, so that daytime sleeping will be less. It's very challenging, I understand, but these are things which can be tried.
Sir, one more thing. Can I add something?
Oh, sure, sure, sure. It's all a group
Uh,
learning. Yeah,
Sir, actually, many times medicines are right, but medicines are given at the wrong time. For example,
yeah.
diuretics are given after 4 o'clock.
Oh,
Steroids
wonderful,
are
Yeah.
given
wonderful.
in the
Correct.
evening.
Yeah,
Steroid is given.
Metoprolol should be given in
good point.
the
Good point.
evening.
Yeah, good point.
So sometimes our medicine push these people to sleep disturbance. Throughout
Yeah,
the night, they will be going to washroom, coming back,
yeah.
and then they will not be able to sleep well.
Even in geriatrics, we were taught even from very long time, try to avoid wherever possible drinking water after 7 o'clock.
Yeah.
There are like it's again debatable, not for everyone. At least for some people it works because
And tea or coffee after 4 o'clock.
yeah, tea or coffee again. Tea or coffee after 6 o'clock, 7 o'clock. These are all, see, all these things are logical things which over experience we can. I think uh, these are so personalized. There is no one answer probably for everything. As doctor told now, medication, prescribing medication is very important. So diuretic may be required in palliative care, providing a diuretic. But
Diuretic.
at what? Yeah, tell me.
Then dexamethasone also one of the point.
Oh, yeah.
Dexamethasone.
Yeah,
Yes.
that also can. Like
Yeah.
all the steroids,
Yeah.
that will actually affect the steroid
Sleep.
axis.
In fact, nowadays they call it as a sleep hygiene. Take some
Yeah, correct,
advising
correct,
sleep
correct,
And
correct.
and it is
hygiene.
for everyone. It is not only for
Yeah,
geriatric
that's
population. It
true.
is for
That's
you
true.
and me as well.
Yeah,
True, true, true.
ma'am. Yeah, ma'am. Yes. Thank you.
So wonderful, wonderful.
Wonderful.
Yeah.
Sir, we have another question by Dr. Fatima. How to
Okay.
manage acute delirium? What medications can be used?
See, again, haloperidol is we call it a vitamin H. Go very small, 0.25, zero point 0.5. Sometimes terminal delirium and all. If it is, sometimes we may have to go in for a higher dose. A cocktail of medication may have to be given, which we need not discuss here. But generally, go very slow. Even 0.25, zero point 0.5, start with that. In quitipin is very safe. Quitipin you can start from 25 milligram, then slowly increase. Then risperidone is another atypical antipsychotic again that can be used. Risperidone 1 milligram can be tried. So risperidone, quitipin, haloperidol, these are three things. Generally, we can, in a common thing, in a discussion like this, those are the ones which we can actually. But again, always better to get a psychiatrist support, because a lot of behavioral and psychiatric issues also go along with this. So managing that, it's always better. It's a quality of care. Better to get, if at all possible, get a psychiatrist support when some things don't get corrected quickly.
Sir, I have a doubt. Uh, I'm working in Pallium for the last 3 years. So we have come across many cases of delirium. And we used to manage delirium in our practice. But recently in my family, there was a case of delirium, and an oncologist has referred her to a psychiatrist. Uh, uh, I was confused, and I couldn't manage. I couldn't prescribe the medicine. Why? Because I couldn't convince the oncologist or the surgeon. So I would like to get your opinion on this. In case of acute delirium, we as a palliative care physician or a geriatric specialist, is it necessary to get opinion from psychiatrist, or can we start the medicine? Which will be better, or which medicine will be better, quetiapine or haloperidol in acute case? It will be. I know as a palliative care physician, but for our doctors here, they some of them have confusion which medicines to be started. Can you please explain that?
Yeah. See, I'll tell you in a medical legal perspective also this one. We had to be very clear. Prescription of medication, there are a lot of schedules, and quitipin, risperidone, all these are scheduled drugs which has to come from respective specialty only. So that is one thing. But in palliative care, we tend to prescribe with a good faith. Good faith, all this medication. So there is no harm, but quetiapine is quite safe. Quetiapine is safe, but always get a supervision or guidance from a psychiatrist in the team. We should have a psychiatrist in the team. Sometimes what happens is, if the psychiatrist is not with a palliative care inclination, then things may not go stay in our hand. Like, we have a very delicate balance with us. We don't want the person to be fully sedated and in bed for the rest of the life. That is not our intention. Our intention is not to create a calm environment just like we see in ICU. In an intensive care unit, the person has to be laid on very calm and silent. So medications are given to the limit, sometimes, which doesn't cause any adversity as otherwise. But that is not our intention. Our intention is basically to keep the medications very low, quantity low, but at the same time we get good result. The person should be wakeable. The person should be, some attention should be there. We should be able to talk to that person in between the delirium also. Sometimes there is there is a waxing and waning of consciousness. So when the person is going to be normal during that cycle, we had to have some meaningful discussion also. So not discussion, at least meaningful conversation with that person. So if we are going to sedate the person completely with round the clock psychoactive medication, we may not be able to provide good palliative care for the person. It may be comfortable for the relatives, that's all, if they don't understand. So it's a very delicate situation. I don't have a clear-cut answer to the question whether we can prescribe it. But if we have a psychiatrist in the team, always get a consent from the psychiatrist, so that he is going to cover you, he or she is going to cover you in case of a need. So some medication like low dose haloperidol will help. Starting low with quitipin can help. Quitipin can be increased. We have given up to 100, 150 milligram quitipin very often. Risperidone can be started. It comes in liquid format also. 1 mg per ml. Drops are also available. It's easy to handle. So you can start from 0.5 milligram, 1 milligram, and go up to 2 milligram. Uh, it can be twice a day. It all depends. Like, so there is no clear-cut answer. But my sincere opinion would be, if the psychiatrist is not inclined to palliative care, or who don't understand the care plan which we have made, then it's going to be a tough decision to go to a psychiatrist. I'm not against any psychiatrist here at all. Um, uh, because it's our problem. We have to discuss with the psychiatrist. It's not the patient. We have to, the care provider, palliative care provider, has to give a good report or a reference letter to the psychiatrist, clearly mentioning this is the situation, this is the care plan which we are planning, and these are the aims, these are the goals and preferences which we have agreed upon with the relative, or this is the patient's wish already. So accordingly, prescribe psychoactive medication. So such reference, sending out a reference appropriate is our responsibility. So little bit careful. I'm not against it. Did I answer to that?
Yes, sir. Yes, it's clear for
Yes,
me.
sir.
In
Great.
a
Yeah, somebody said regarding
the
the
associated.
investigation. Can I add a
So
point? Aditya, please.
Hello, sir. Good evening.
Yeah.
So, regarding investigation, I wanted to say that we basically do investigation in delirium to understand the underlying causes,
Yeah.
like from metabolic cause to sepsis, dyselectrolemia, hypoxia, hypercapnia, PK, HHS. It throws a lot of evidence on what is causing the delirium. And we always try to treat the cause of delirium than the delirium per se. We try to address delirium when the symptoms are very creating huge burden to the patient, and when it's a terminal delirium where you are unable to correct the correctables, that kind of situation. Plus, another point regarding investigation, there are some recent upcoming researches on the level of serum acetylcholinesterase in the diagnosis of delirium. So there have been two articles published in the area of palliative care itself. Actually, those are Western articles. No study has been published yet in India, and they have found that serum acetylcholinesterase activity is higher in patients with hyperactive delirium. So again, we know that hyperactive delirium is one of the most dangerous type of delirium because we miss out the diagnosis most of the time. So for that delirium, this investigation has shown to increase the diagnostic efficacy. This might be a very controversial point, but still it is something under research, and there are scope for further research in this area also. And again, based on evidences, there was a publication by MD Anderson, and they have found out that when patients are being referred to palliative care, around 61% of the patients delirium is missed out by the primary team. So they might be referred for something like pain or some other symptom management, but delirium will be missed out in 61% of the patients. So in a situation where we are unable to diagnose delirium, we can always make use of various assessment scores which are available, so that we can effectively diagnose delirium at the earliest. Before the patient goes into coma, we can pick up delirium. So these kind of scores
Aditya, actually, I don't know. You have picked up a very important point with acetyl choline, and definitely it is. I don't know how much. I don't know what is the mix of an audience here, but everybody. Actually, choline research has been going on for quite some time. It's actually a critical neurotransmitter in the brain. So there is no doubt it plays a very essential role in all the cognitive function like attention, memory, cognition, recognition, all those things. It's the most critical neurotransmitter, and it's that neurotransmitter which affects dementia also. So that is a link. That's a link, and the cholinergic system, which again relies on acetylcholine. This is involved in regulating all the sleep-wake cycle, wakefulness, and arousal. Suddenly when the sun rises, with melatonin hormone, all those things. So arousal and all the cognitive process. It's actually closely linked to the cholinergic system, which fully relies on acetylcholine. So in older adults, usually the cholinergic system is compromised, even otherwise, due to aging and due to a lot of neurodegenerative condition. And it need not be medical condition alone. There is neurodegeneration going on. That is one reason why older people do tend to have delirium most commonly, not with younger age group. One reason is because of the weak cholinergic system and because of the neurodegenerative condition. There is brain atrophy happening. So there is a lot of link between acetylcholine deficiency and delirium. It's often it's the deficiency. So even people have tried, like acetylcholinesterase inhibitors, like rivastigmin, donepezil. All these things has been tried out. I don't know. I'm not very sure whether donepezil will have a significant effect with in delirium. I have actually tried out donepezil with delirium when I suspected dementia. When I suspected the person has an early dementia, which was gone unnoticed, but suddenly with infection there is delirium, and donepezil had been tried. The problem here is we don't have guidelines on whether to use acetylcholinesterase inhibitors like rivastigmin here for delirium, but doctors can actually prescribe. There is no harm. I won't say I am, whenever I prescribe donepezil in such a condition, I do suspect a baseline acetylcholine deficiency also. So logically, inhibiting the acetylcholinesterase, which is going to break down acetylcholine, should logically improve the situation, delirium. So this is quite, as you said, Aditya, as you said, it is quite debatable. There is no guideline as such, but doctors like us, we have tried it out. It becomes unethical trying such medication when we don't have good data on it or just trying it out. So my suggestion would be still a geriatrician or a physician who is very sure that there is going to be some a cholinergic deficiency, then this can be taken care. Thank you for bringing it up. There are a lot of research happening in this area. Thanks a lot.
Hello, Praveen.
Thank you.
Yeah.
Hello, Dr. Praveen. I am Rajashree.
Yeah.
I'm speaking from Thrissur. I work for Thrissur Pain and Palliative Care Clinic, and also I'm a part-time consultant with Amrita Institute of Medical Science. I know
Dr. Rajashree, I know you. I am.
Yes, yes.
Yeah,
Yes,
Hi.
I remember you.
Yeah.
So, thank you for the wonderful presentation and the very good suggestions which came up in the chat box and also during discussion. And simple points like polypharmacy, preventing falls, and taking history from the caregivers, and looking at small, but very big issues like constipation, and like highlighting the points like who is this and who are they, instead of that just tell them this is this person, such and such person who has come to meet you. These are very valid points. Thank you for that. And also the participants. Regarding, I have one comment regarding the use of antipsychotics. Low dose antipsychotics can be prescribed effectively and safely by any practitioner who is proficient in prescribing them. That means that cannot be written and prescribed as and when you come across with a restless patient. But before that, before prescribing an antipsychotic like haloperidol or capine or risperidone, you should be able to assess what the condition is and what has contributed to it. And you should be very familiar with the pharmacokinetics and the dynamics of the medication. Because in patients and elderly patients are very prone to have other neurodegenerative conditions like Parkinsonism. In such patients, antipsychotics will not be, or we can use it with caution. Otherwise, haloperidol and other antipsychotic medications are supposed to be kept in the toolkit or the medicine box of any palliative care unit. That can be carried in the home care team and can be dispensed. That doesn't mean that it can be prescribed irrationally. We do that because antipsychotics, we know that is a first line medications to clear the clogged sensorium. And meanwhile, we have to take a clear history, whether the patient is hypoactive or hyperactive, or if the patient is in the ICU or in the ward in the home, or if the patient is mechanically ventilated or spontaneously breathing. The clinical history and the examination is very vital. That is what I understand. And it's true that, Dr. Aditya, probably there will be evidences from the Western countries that the role of acetylcholine esterase and the use of acetylcholine inhibitors. But we should not forget the basic investigations starting from, as you have highlighted, CBC, GRBS or serum electrolytes and other basic parameters. Most of the time, they will just give you a clue to what has really contributed to delirium. This is what I have to comment. Thank you.
Thanks a lot, Dr. Ashley.
Yeah, I think it was a very wonderful session, an interactive session. Thanks to all the doctors and thanks to Dr. Praveen sir also. So to summarize this delirium session, yes, we have to identify the delirium without missing the diagnosis. We have to be with the patient. We have to take the history properly. Then only we can get a clear idea about the patient and the family. And once we make the diagnosis, we should identify if there is any correctables. So I would like to mention a few correctables like urinary tract infection, bed sore, constipation, oral thrush. These are very common in old age and in geriatric or palliative care patients. And bed sore, even a small wound or change in environment like shifting the patient to hospital or anything it can be. So we have to assess the history properly, and this can fluctuate within the day itself. So once we diagnose, we should identify the correctable, and we can, as ma'am said, and sir has explained, we can do the necessary investigations like CBC, serum electrolytes, if it is necessary. And after correcting the correctables, along with that, we have to start the antipsychotics like haloperidol or quetiapine. So we can take the opinion from the psychiatrist also, because the symptom is very common with the psychiatric symptoms like restlessness, agitation, and so we can take an opinion from them also. So and after that, once we diagnose the delirium, we should sit with the family. So they may be very confused, and they may be very much worried. Why? Because sometimes the patient may not be identifying their near ones, or like that way. The situation may vary. So anyway, the family may be panicked when they come across such situation like agitation, and sometimes they may not sit calm. They may be running around the house, or they may be throwing or calling bad words or something like that, or like that way. So we should sit with the family. We cannot make the patient understand the situation, but we can sit with the family and make them understand this is the situation going on. These are the things we can do. We should make a plan with the family members. And in between, if the patient become awake or conscious, so they may be also worried what happened to me, like that way. So you can just communicate to them if they are aware in between, or you can ask them what is going on in their mind. Sometimes even uh, minor things it may be, so we should keep an eye on that also. And after that, in end of life or in terminal stages and all, we may not be able to completely, as sir said, we in some cases we may not be in some of the cases, in most of the cases, if there is a correctable, we can manage the delirium. So for example, if there is a pain after starting opioid or an analgesic itself, the pain subsides, the patient's delirium stage reverse. Okay, so it is reversible, not like dementia. It is reversible. So we should